Please do note that this webinar is being recorded. That means that you have given permit for that to happen, but that also you will receive the recording. So if you need to leave at any time, do not worry, because the whole session will be saved, and then after some time we will upload everything to YouTube, so it doesn't expire in our SharePoint. So welcome today, as I said before, to the 5th session of the Transparency series that we have been running throughout 2025. This session is titled Forward, Backward, Stack, Rethinking Transparency in Pharma Policy. And we have today with us two panelists, Juliana Veras from Médecins du Monde, and I will introduce her better when she's starting, and George Schaber from Buco Pharma Campaign. Both organizations are co-organizing this webinar with Salud por Derecho. As you know, as part of these webinars, we have been exploring different aspects of transparency, particularly in regards with the implementation of the transparency resolution in a number of contexts. We have explored transparency developments in Spain, civil society efforts in Colombia and South Africa, also developments regarding to the EU Transparency Directive and the efforts of Ugandan civil society to advance the right to health in relation to transparency of pharmaceutical markets, among other topics. And today we are exploring updates in the European context, updates that are good news, some others are bad news, and some others are just probably reproducing the status quo. But that's the reason we have invited both Juliana and Jörg to give us a bit of context of how the whole transparency ecosystem, so to speak, work both in Germany and in France, and what has been happening in the last years that can be a lesson to be explored in other contexts. As a general overview and a quick policy update for setting the scene for this webinar, and as we have many colleagues joining not only from Europe but from other parts of the world, we have had a development yesterday on the provisional agreement of the EU pharma legislation in the directive that will have to be implemented by member states in the European Union that makes mandatory the transparency on public funding as per the wording that you see on the screen. So now, irrespective of the geographic location of the donor, if the money has been given by a public authority, a public funded body, a philanthropy organization, or a not-for-profit, then the company will have to make that public funding transparent, which is not bad news due to the current climate in the European Union. So with this quick update that we will revisit, I want to present you now to Jörg Schaber, and sorry if I mispronounce it again. He's a sociologist and Master of Public Health working for the German NGO Buco Pharma Campaign since 1981, and he's the editor of Pharma Brief. He's also a co-founder of Health Action International, and he has been a patient representative in the drug committee of the Federal Joint Committee in GBA, which decides about reimbursement of drugs in Germany. From 2008 to 2016, he was the president of the International Society of Drug Bulletins, and he will present the case of Germany. So over to you. I will stop sharing now, and you have the floor, Jörg.
Good afternoon to everybody. A few people I recognize by names. Hello to them, hello to everybody else. I hope I'm loud enough for you. Yeah, I should tell something about the situation on prices and transparency in Germany. I think that's relevant to a certain extent because Germany is the reference country for many other countries when they set their prices. And yeah, you should know the advantages and disadvantages about this German system. Some key facts in the beginning: it's the largest pharmaceutical market in Europe. Alone the public system are nearly 60 billion euros spent on medicines, and this is not it does not include the medicines which are distributed in hospitals, because this is reimbursed as a lump sum to the hospitals, and it's not so easy to identify. So the market in effect is even bigger. Yeah, one thing which often causes misunderstandings: Germany, at least in a European context, is a bit special because the social security system reimburse all new drugs from day one when they come on the market. So that's really different from other countries. And that may have a few times advantages, but has a lot of disadvantages too. The only exception which drugs get never reimbursed are so-called lifestyle drugs. And I come to that back later a bit. When we're talking about price, the health technology assessment is done relatively quick, within 6 months from the start of marketing. And it is the base for the price agreements between the companies and the health insurers, but it has directly no exclusion rights. So if there's a negative assessment, that does not mean that the drug will no longer be available through the health system. Yeah, then we talk about the problems we have. Germany is a rather rich country, but still the patented drugs are a big burden. If you look to the left graph, you can see that the cost to the system, patent protected drugs nearly amount for 60% of the total cost. And if you look at the right graph, you see it's only 7.1% of the daily doses prescribed. And that's one thing. So there's a lot of money, but also it increases. So in the last 10 years, the cost nearly doubled. When we're talking about price transparency, generally, yes, there is price transparency. I'll show you in a second. We have a lot of Festbeträge, fixed amounts. I don't know whether this is a proper translation. So the system sets a maximum price which will be reimbursed, and if it's more expensive, the patients will have a bigger co-payment. And so these prices are known. Then there's also a lot of rebate agreements in the public health, by the public health insurers, and that's really a black box. We can assume that the prices are lower than the fixed amounts agreed, but because that's the aim, but we don't know exactly, and the health insurers claim that the savings have been 1 to 2 billion euros per year. And when we talk about new drugs, which are the most costly drugs to the system, we have only very recently, compared to other European countries, a systematic health technology assessment. And we also know the prices which are agreed in the system. But we have, and I come back to that later, the so-called Lex Lilly, which tries to destroy this transparency. Okay, where do I find prices? As you will get the presentation afterwards, you can look for yourself. The health system has a searchable database, which is quite extensive and gives you the number of prescriptions, the total cost, the cost per defined daily dose. So, and that's, as I was confirmed today, the real price we pay. So it's also for the patented drugs, the reduced price which was bargained between manufacturer and the health system. Nevertheless, we spend a lot of money on few drugs. Just the first two examples from the table you probably can't read on the screen. is apixaban, an anticoagulant, and pembrolizumab, a cancer drug, which each cost about 1.6 billion euros, the health system. But you feel free to look into this database and you can see all the prices. Yeah, we have price transparency and we have assessment transparency. I think that's also an important factor. And because the price decisions can only be as good as the evidence base behind the added value of a new drug is presented. And what is special about the German law is that the manufacturers are obliged to provide the complete study data. So it's not enough to give the publications of the clinical studies, but they have to give the complete data. And that makes a difference. I'll show one or two examples just after this. And we have a two-step system. So it's an independent institute called IQWiG. I save you from the long name, which does the assessment of the new drug, and it gets public before the final decision. And there's a hearing with manufacturers and experts with a verbatim transcript, which sometimes can be quite interesting because there's sometimes a gap between what the manufacturer claims how severe the illness is and how much his new drug helps against this. And in the end, when the decision is made by the Federal Joint Committee, which I was a member as a patient representative for many years, the reasoning for the decision is also publicly available. Part of the documents are also available in English, but not all. And if we look at the assessments, if we look at the left graph first, we see that there's only a small proportion which are a real advantage in the new drugs. It's 1.5% of all assessments. And another 16-70% are really considerably better than existing therapies. And then we have a 15% little better, 90% not quantifiable. And that's really also an evidence black box. That's often orphan drugs, which have been very poorly researched only and come very early on the market. And then we have nearly 47% of drugs which don't offer any advantage over existing therapies. And if you look at how patients could profiteer from it, we see that it's even looking worse because in the assessment process, we look also for how big the patient groups are. And then we see that for more than 70% of the patients, the new drugs don't give any advantage. Yeah, assessment transparency is a bit older example, but it's still valid. The drug's still on the market and it's a lot prescribed still a lot. And I compare the English assessment by NICE with the German assessment, which was done in the same year. And one thing which interests us in cancer drugs is, do they really prolong survival of the patients? And that's what we can see in the NICE assessment. That's what gets public. It's a lot of black. And you can't really guess whether there's a survival benefit. And if you look at the German data, you can see the data on the right side. The data exists and it's available because the manufacturer had to give the complete data, and it shows that at this stage, there was no survival benefit at all. And that meant that the price was considerably cut. So from a start price of over 66,000 euros down to 30,000 euros. And that was part of the decision. And also, a UK group really wanted to find out why the NICE board didn't want to give the data and didn't even a freedom of information request. I think this is a really memorable sentence. Protecting the commercial interests of Pfizer and NICE outweighs the public interest in disclosure of the clinical data. That's, I find, really disgusting. Another example for unpublished data is just very recent, the assessment of lecanemab, an Alzheimer drug, was just finished by IQWiC, and they had also the complete data, and so they could really look at the indication which was licensed in the end, because in the first licensing procedure in the EU, the drug failed. And so only in the second go, they got green light only for limited patient groups, not for the patients which potentially could profit here most, because the drug was deemed too dangerous for them. So if you look at the two stages of disease, or it was licensed, and look at the data, there's no added benefit in either group, and also can see through the link the data. As I said earlier, the benefit assessment does not mean exclusion in the first place, but sometimes it ends up as an exclusion, and in this case, by the manufacturer who decides not to market the drug in Germany then. And this was a omega-3 product in dyslipidemia, had no added benefit, and it cost a lot of money, 3,000 euros, plus simvastatin, so it was a combination. And if you compare to simvastatin alone, to which it was compared, which is less than 100 euros. And though the decision of the manufacturer said, okay, we couldn't bargain a price which was sufficient for us, so we withdrew from the market. Which in this case was a good decision, because it's really a waste of money. Yeah, now we come to Lex Lilly. This is about tirzepatide. Sorry, in English, you add an E to the end, to the INN. I didn't do that everywhere. So the drug has a dual use, so for diabetes and weight reduction. And in diabetes, the assessment was not so positive. So of the 8 patient groups which differ, only in one group there was seen a minor added benefit. And the price of the drug, more than 3,000 euros. And the cheapest comparator drug, about 100 euros. What does that mean? The price will be drastically reduced in the agreement between manufacturer and health insurers. And Lilly did not like the idea that this price comes to the public. And what they do then? Because for the weight loss indication, that's in Germany, at least it's a private market, so the health insurers will never reimburse drugs which are used for weight control. And so Lilly decided, well, we better keep it secret. And what they did do, they promised the German government to build a new factory in Germany. And in return, they wanted to have a secret price. And what you see in the right side, these important people with spades in their hand, that was the, how do we say this in English, Grundsteinlegung. Well, the celebration to start the building of the factory. And attending were the then chancellor and the health minister. But the ministry said, oh no, there's no, the discount policy played no role in the location decision for the new plant. But unfortunately, this is not true, because by freedom of information request, a group of journalists got, after some lawsuits, the internal communication from the ministry, in the ministry. Just read it out because it's so, Eli Lilly links its investment decision on a commitment by the federal government to allow for secret rebates with innovative drugs. That's the reasoning. And then the order is for a meeting which was already planned with Dave Ricks, the CEO of Eli Lilly. He can be told that the health ministry plans to fulfill his wish. So why is that so bad? Doctors can no longer prescribe economically because they simply don't know the price. And it opens the door for Lilly to marketing because Lilly promises a fair price for diabetic patients. It also sets really a bad example against transparency, and we need to see whether other companies will follow because it's on application only. And anyway, it's unfair to other countries because they can't see the real price any longer. So what else is important? I've made the most important pros and cons to my point of view. We have a sound and transparent HTA process in Germany. In brackets, we have to see how the European HTA process will fit into this, and it has partially less transparency. It starts earlier. I think we have to keep an eye on that. In the law, it's written that Me Too drugs, so similar drugs to or existing drugs with no added value, have to be at least 20% cheaper. And something which is unusual is also when evidence is very poor, post-marketing studies can be mandated by the Federal Joint Committee, and this is done. It's happening especially with orphan drugs, which are sometimes in the millions per patient. Yeah, cons, pricing does not work well when the comparator drug is already expensive. You know, a quite large amount of new drugs are cancer medicines, and when the price of the comparator is already 50,000, 80,000, 100,000 euros, even if the company gets less for its drug, it's still a good deal for the company. And obviously, the lack of bargaining power of the health insurers seems to be obvious. I'll show this in the next slide. And one part of this is that we don't have a cost ceiling as other countries have. So euro per DALY disability adjusted life years, which still are acceptable to the system. And if you can see here, I've only got a funded table from 2021. You see there's reductions up to 70%, but sometimes the reductions are very small. For example, for inclisiran, cardiovascular drug with no added benefit, the price reduction was just 6%. And if you have a target group of 400,000 patients, that means quite a loss of money. Okay, that was it. That's a bit of advertising, and then I'm finished.
Thanks a lot, Jörg. There are very, very interesting things that you have been sharing with us that I would love to take them further to the Q&A. But just before introducing Juliana, a few points. What you have mentioned about transparency of health technology assessment that we have only briefly touched upon one of our seminars in the case of Spain, I think is critical because sometimes we're just like also from the civil society, we're framing transparency around prices, but it's worth remembering every time that transparency also is a matter of patient security and demonstrating added value at the end. And then on what you said about what happens if there is no added value, that sometimes is good news because they retreat from the market, they withdraw. There is also the other side of the coin that sometimes, and this has been reported by Investigate Europe, that I have shared one of the articles in the chat. Sometimes they have that much power, and we have such an asymmetry of information that we don't know even that if they are retreating with a good drug or a bad drug, because lack of transparency covers the whole continuum on that. So I would love if we can resume this in the Q&A, but now I will introduce you to Juliana Veras. And sorry, Juliana, because I have to look up for your extensive curriculum vitae again. But Juliana Veras is responsible for pharmaceutical policy in Médecins du Monde. We invited her today to discuss the recent updates, that very, very exciting updates in French politics regarding transparency, but also to give us a general picture of what's happening in France regarding price transparency and what Doctors of the World, Médecins du Monde, is doing about it. So over to you. Sorry, without your bio, that it's in the link of the webinar. Go ahead, Juliana.
Thank you, Jaime. Do you see my screen? Or?
Yeah, just click the button just below your picture that says present in Teams, and then we will see it full screen. In the PowerPoint deck,
oui.
right corner on the top, you can see a picture of yourself. This? Yeah, now it's working perfectly.
Do you see me?
Yeah.
So thank you very much, Salud, for inviting us to be here, sharing our experience in France. So just to give you just a context about who is Médecins du Monde, we are a French medical humanitarian NGO. And we have programs, international programs, and we have strong advocacy in France, where we have also a lot of projects, and where we advocate for in defense of the public health system. Notably, we defend it from the current attacks we have witnessed from our programs in the last years. So we advocate for affordable access to medicine since 2014, and so we started to work on pharmaceutical policy when we witnessed the exclusion of patients in our harm reduction programs, and they were refused access to innovative hepatitis C treatment by that time. So this lack of access was related to sofosbuvir, that a lot of you know, and so the price was very expensive, and well, that's when we started effectively to look for understanding the French landscape on surrounding the pharmaceutical policy, and also the environment on price negotiations. So in doing that, we worked a lot in coalitions and with colleagues that you know in French civil society. So we started this advocacy on challenging patent barriers, and so just to give you a landscape of the price negotiations in France. So it was quite new for us at the beginning, but in France, basically you have two main steps, right, for regarding price negotiations of patented therapies. The first step is once the companies have their European market authorization, so they can seek to include the product in the SUS list. That's called. It's a list. It's a mechanism that through which the health insurance reimburses the most expensive medicines outside hospital budgets. So since the launch of sofosbuvir, as you can see, 2013, so it was negotiated 1 year after at 41,000 euros. So since then, you have really, we have seen a sharp increase in spending on new patented therapies covered under the list en sus, right? So, but this is not the final price, as it happens in Germany. We have a second step, and then we have this price negotiation process with a lot of stakeholders. Notably, so the main actor that negotiate prices is the CEPS that you can see in the screen. Sorry, it's in French. The CEPS is here in the center of the screen. And the negotiation is based on the reports of the Haute Autorité de Santé, which is the health technology assessment authority. So they evaluate the actual interest on the drug, comparing with the already existing available technologies. So it's a process that it's based on reports, and for us it's quite opaque, since it's protected by trade secrets. And on the other hand, you have also like it's not based on the law, but they have like an agreement between the pharmaceutical industry and the CEPS. So, and sorry, just to come back in this slide. So one of the consequences that have been noticed in France regarding the price negotiation in France, one of the effects, the consequences, is that this process, actually as it works today, has helped to increase shortages. Why? Because on the one hand, by benefiting patented, benefiting high prices in the negotiations of patented medicines, we have on the other hand another effect that the mature drugs, notably the old ones, the generic ones, had their price lowered. They have what created an impact, because it's about an envelope, right? So this appeared in some reports, but we don't have some, not reports from the CEPS, from other reports from French authorities. So as a consequence, we have this unbalanced price negotiation with no publication of net prices. Net prices are not published. Only the aggregated data on rebates that are given. So it doesn't help us to understand how this process works. And we also have R&D and production costs that are excluded from the negotiation, notably public investments that are not part of the negotiation. This image is from a book that I will show you later, but this is to show the unbalanced negotiation process in France. So what we have after the transparency resolution in 2019, we had some outcomes from civil society advocacy. So in 2020, we had an amendment inspired by civil society, which was introduced this idea of transparency of public investments that was included in the social security bill. So we proposed an amendment during the vote of the annual vote of the Social Security bill, but the final version of the amendment was watered down, leaving the implementation to a decree. So the companies, they had the the obligation to declare, not the obligation, they were invited to declare the amount of public funding that they received for research and development. And then, well, it was not very precise. There was no specific language, but this amount was sought to be made public, okay? And it was supposed to be implemented by a decree. So in 2021, the Minister of Health, by that time, who had previously chaired the Social Affairs Commission in the French National Assembly, committed to advancing in this project of this amendment that became an article of the Social Security Bill within the executive branch. So we pushed for a stronger language for the application of the decree. But unfortunately, the final version of the decree was unworkable and completely disconnected from the spirit of the transparency resolution. In practice, we ended up with a no binding obligation to declare public funding. The requirement covered only French public funds, excluding cross-country cumulative funds. And we asked, well, they only they only had the obligation to report aggregated data rather than drug-specific data, and it focused only on direct funding, excluding all indirect funding, such as the crédit impôt recherche, which is research tax credits, which remained, according to the Ministry of Finance by that time, it was protected not by trade secrets, but by the tax secrecy. So as a result, well, the decree, which was meant to, strengthen the state's bargaining power to negotiate fair prices, turned to be a complete failure. And when the first report was published, the first report of the CEPS was published, only 7 companies had declared 3 million in public funding, while we knew by that time that Sanofi alone received 150 million in research tax credits. But, well, it was, at least it was, this process showed that what civil society was denouncing for a lot of years, that without binding obligations and a strong political will, nothing would rather change in the pharmaceutical sectors. So, okay, we feel now that there is an emerging consensus among public stakeholders that the current level of public spending, at least on high-priced medicines, is unsustainable. So we have seen several reports coming. So you have institutions, National Health Insurance, l'assurance maladie, the National Health Insurance Fund, the Court of Auditors, the Council of State, le Conseil d'État. Well, more recently, we had 2 Senate inquiry commissions that have made a strong case on transparency. So in 2023, the Senate Inquiry Commission on Medicine Shortages have made recommendations. And, well, and more recently, we had a tension between the Senate and Sanofi during an audition regarding the crédit impôt recherche, the tax on the tax exemption on research. And, well, we have been, during the years, we have been pushing for recommendations, and notably of the fact that health falls outside the scope of trade secret. There is legislation that asserts it. The fact that we have been advocating for transparency of net prices and R&D costs, and of cumulative public funding across countries. We have been pushing for regulation of profit limits in drug pricing negotiations. And more recently, we have started to advocate for ex ante and ex post cost investigations during price negotiations, which is in line with the Public Procurement Code. So this is already practiced in the Ministry of Armies, but in Defense, Ministry of Defense, but not in the Ministry of Health. So we have been pushing for it, and we have pushing for strengthening European and international cooperation. So just to, so this is the last idea that I want to share. During the annual budget discussions this year, there was some amendments that were presented. Every year, civil society presents the same amendments regarding transparency. And we had like an interesting amendment that came from le Parti Socialiste, notamment. But we also asked for it, but the languages were very interesting because it asked for the state of IP rights of mergers or acquisitions related to the product, public and private research structures involved in the discovery of the API, transparency on the origin of amount of the public investments, direct and indirect investments that supported R&D. And then the amendment called for an obligation, so it should be binding with binding to declare annual R&D spending, marketing costs and prices, sale volumes. So, and so this text was adopted by the Social Affairs Committee, but unfortunately the National Assembly and the Senate didn't vote it during the plenary session because, it was ruled inadmissible. So that said, it was for procedural reasons. So they didn't really debate it in the plenary sessions. And the other amendment that was quite controversial was this one regarding the net prices of medicines. And so it aimed to make public the net prices and rebates that are paid by the health insurance. And this text was adopted at the first reading by the National Assembly and rejected by the Senate. And ultimately, it was also rejected during the second reading by the National Assembly. And what is quite interesting is that I think that we never were confronted to the need to discuss net prices transparency. Something that we always asked, but we have seen that during the vote there was a lot of lobbying from the Pharma in the voting process. And we have seen parties that initially voted for it changing their orientations. They started to repeat pharma industry arguments. So, which are the fact that it would affect the trade secrets. So this is the fact that industry will quit the French market, the fact that the CEPS do a great job in negotiating prices. And this was quite upsetting because even we feel that, in the civil society, there has been a lot of changing, not changing, but at least there were some positions that were new, in the sense that civil society perhaps has shifted its opinion also locally. And this is a big challenge because we don't know yet how we will continue to work together on drug net prices. So, I'll stop here, but now I think that it would be very interesting if we could try to think on ways to work together among countries, among civil society, European civil society, in order to try to perhaps structure an advocacy cross-country regarding net prices transparency, because notably, for instance, on working on rebates, on mapping rebates among European countries. Well, and that's what I would like to share with you. But that's it. Thank you.
Thanks, Juliana. And we are going to open the floor for questions and also for comments on the panelists' presentations. So please raise your hand or write a comment. In the meantime, as people as people start asking questions, if they have some, I have some for you both. And one thing that has been common in your presentations has been that there is always some sort of blackmailing regarding the pharmaceutical industry. It can be regarding whether they will open a new factory or whether they withdraw investment in R&D or the similar. And this is not the first time we see that in Europe. In Investigate Europe a series on investigative journalism, they reported that this has been the case across all European countries, and I will present some of those so that you can read them, that I have been collecting while the presenters were on it. Sorry. So this is verbatim from the Serious Deadly Prices, where the one head of pharmaceutical policy at the Belgian National Institute of Health said that there is always threats that the company is not going to sit at the negotiating table, and this has been heard all the time, everywhere. That's the same for Austria, where they say that there is always this kind of stupid primitive game, as the definition by the representative. And this is also even worse in smaller markets, Eastern European countries, and so on. So my question to you. To you both, but especially first to Juliana, because you have mentioned this, is there is a consensus, you've used this word, on how unsustainable pharmaceutical budgets are nowadays. How can we, as civil society, use that consensus to move things forward? Because from this evidence and what George has presented and yourself, we see that no one is happy with the current situation, but how can we do to better catalyze this and move the conversation forward, in your opinion, or in the reflections that civil society in France has had with the latest developments? And I throw one also to Jörg, and is regarding the role of Germany as a powerful player, not only nationally but regionally, determining EU politics. And this was also part of Investigate Europe. They were looking both at Denmark and Germany, and how opacity work. And one of the things that we have been pushing Spain to advocate for, but also with EU decision makers, is strengthening EURIPID as a database for price sharing. But this is something that Germany has repeatedly opposed, and I think Germany is not part of EURIPID, so the information, if they have discounts, is not public there. And is that the same thing for Denmark, which is not the case for other countries, such as Austria, where they flag every time there is a discount or a market entry agreement, so that people knows that that's not the real price. And my question then to you is, how like what opportunities do you see for civil society in Germany, but also how to influence Germany because of their power within the European Union, the European Commission, and the European Parliament due to the German population and the representation they get in Europe, to move also this conversation forward, as things are obviously also not perfect in HTA transparency, price transparency, and so on in Germany. So how do you see that for the Germany case alone, and also how we can help civil society from around the world in moving these things in Germany?
Can I answer, Jaime?
Yes.
So what we have experienced at least is that yes, we have seen a lot of stakeholders in France taking position. So it's a consensus that is not that the stake is taken in an isolated form. Let's say that people are talking to each other through reports. So it's very complex because we don't really have a space for dialogue around transparency. We don't have the only well, we have seen that with the Ministry of Health, it's complicated because well, it's complicated with the government right now, but we don't have a forum, a space in which people who thinks the same can exchange around the policy, the pharmaceutical policy. So we need this space, but we also need to. I mean, this is a way that we hope we could build. We could build in order to even to make civil society working together around this topic, because well, what happened in this during the voting of the Social Security bill is that we were completely disconnected to our partners, historical partners in this fight. So this was quite a difficult moment, I think, and that's why I think we lost. But we need to have the space to so that people, everyone, feels secure, safe on the fact that we don't need to how can I say how can I say to accept the blackmailing that is right now happening, that is very intense. So because we don't have a space today, and we need to build this space, even with our European partners.
Shall I continue? Yeah, difficult questions, really. While doing this work for quite a while, Germany is a very pharma-friendly country. For many years, Germany has been the largest drug exporting country of the world. They're still proud of it, although it's multinational companies, not on very few are really German, so it's a bit strange anyway. So anyway, they'll pay a bit of tax here. And already with the last government, with the so-called traffic light coalition, the Green Party in government became quite industry friendly. It was not very accessible anymore. And this has not really improved with the Social Democrats and the Conservatives now in the government. And I think the general mood is really very farmer friendly. And it's blackmail, I think, is the right term, but politicians don't perceive it as such. But if you see what regulations come into force, for example, which I didn't mention, a recent regulation, a recent law which allows for higher prices if part of the clinical studies have been done in Germany for a certain drug. Things like this, which, well, what's the benefit of this? And either a clinical study is done properly and represents the patients which should take the drug later or doesn't. It doesn't really matter where the clinical study is done, if it's done properly. Things like that. So it's really seen in the pharmaceutical industry as an investment case. And what politicians tend to forget, who pays the bill for that? We pay the bill as the people in the health insurance system who pay the fees. And so it's economic growth on the cost of the people.
Thanks. And there is actually a question for you from Nicholas from Prescree. How can you explain that the drug budget doubled within 10 years in Germany? Is it only due to high prices of new drugs?
Well, there's a small component of more drugs prescribed per capita, but the largest amount is that the entry prices of new drugs have increased so much over the last years. I could have shown a graph on that too. So the component that prices per new drug going up so quickly, that's a major problem.
Thanks. I will comment a couple of things because we are coming to the time limit of the webinar. So let's try to be respectful with the time of the people connected. So just a few sentences for finishing. Very interesting what you mentioned of the thing that if the clinical trial was done in Germany, then that would be some sort of reward for the company, because that had been tabled also in the pharma regulation, in the pharma package. I don't know, it didn't make it to the final text, but that was one of the things tabled by I think it's the socialist group, that if the clinical trial was done in Europe, then more exclusivities, which is more money for the pharmaceutical company, which is also a weird incentive to give to the pharma company, because at the end the access will be blocked because of the high prices. So we will get to nowhere. And coming back to the space for dialogue that Juliana said, yes, of course, this is something that we have been exploring also in this series, and is how civil society are making progress in different fronts. And still being a player that can deliver change, even though if those legislative changes doesn't go through. We have had very positive examples of health justice initiative with the vaccine contracts in South Africa. We have the Transparency Core for Clinical Trial Cost Reporting Transparency by MSF, the recent report by Hayan Wemos, published in the chat by the colleagues, that have led to some events also in the European Parliament, which points at the fact that civil society is still there, a player for both the provision of global public goods and mitigation of negative externalities, as we presented in one of our webinars. And these kind of spaces, like the one that we are creating with this series, also give ideas for strategies. For instance, this is one example of things that have moved forward. For instance, what Juliana just presented of these articles on the civil society mobilization in 2020, but also what we saw in Spain in the Royal Decree on Health Technology Assessment, where there is an obligation to provide accurate production costs, which at the end, what we see is that CSOs are an important part of systemic change that is still needed. And many strategies can also be learned from here. I just took note of what Juliana just mentioned about this ex-ante, ex-post evaluation that was done on some parts of the public procurement, but not on others. That's something that definitely we're going to check for the case of Spain. And for instance, also the fact that MSF developed the Transparency Core Clinical Trial Cost Reporting Toolkit has been an anchor for Salud por Derechos asks to the Ministry of Health here in Spain to look for the cost of clinical trial within the public sector. That's something that they can do for the hospitals that are at least completely publicly funded and that they run clinical trials. So I want to also close this session with a note of optimism that civil society still creates changes, still drives the transparency agenda forward, and that we have to probably now be able to do more or at least the same with less resources than before. And one cost-efficient way of doing that is by grouping back together, strategize, create these spaces for dialogue and collective action. And we hope this kind of webinars also spark that flame up, that people that attend here at the end of the day also get some ideas, put their efforts together. So please feel free, all the people that have been here today, to drop us an email if you want to contact either of the panelists or ourselves in order to bring forces together and to move these agendas forward. So that's everything on my side. I want to say thanks to Buko and Médecins du Monde, to Juliana and George for finding the time to be in here, and for all the participants that have joined us today. The recording will be available, and so the PPTs. So thanks a lot, and hope to see you in the next episode that we will launch in January, that is already confirmed, and we will talk about securitization in pharmaceutical policy, how the use of defense funds is being very high in the agenda for the Critical Medicines Act, and how that is being replicated in other contexts in North of Africa. So thanks a lot, and see you soon in other spaces. Bye.